My name is Dr. Tanya Trinh, and I'm a staff specialist at Sydney Eye Hospital. And I'm honoured to speak to you today about an evidence-based discussion of gender bias in medicine and ophthalmology. And the title of the talk is Engendered Lenses We Trust, the Quest for Clarity. 6 months ago, I received an anonymous gift in the mail. Just a message, no identity of who it was. It was a scrub cap. It's simple, unfussy, and it states my name, my title, and my position as an ophthalmologist. At first, I was confused as to why someone would send me a gift like this, because this sort of named attire is not a thing in Australia. Culturally here, it is seen a little like grandstanding. So maybe it was just a nice, friendly gift. Did they really expect me to wear it? Who sent it to me? And perhaps did they think that I needed it? A few days later, my best friend, she herself an orthopedic surgeon, rang to see if I'd received the gift. And she said, "I heard what you were going through and thought you could do with this." What I was going through had taken place a few months earlier. It was my second day of being an attending. I walked in and introduced myself. "Hi, I'm Dr. Tanya Trinh. Welcome to Mossman Eye Center." I proceeded to take the patient through their history, the examination, what a cataract was, their ocular comorbidities, the lens technologies we had, consented them for the risks, benefits, pros and cons of surgery, and was writing up the last of my notes when my patient, a retired male radiologist, leaned forward and said, "So, has the surgeon done many of these cases?" The next week, I wandered into my first public operating list. Without even being given a chance to introduce myself, I was directed to the whiteboard by the female scrub nurse and asked to write my name in the medical student section. And a few days later at my private operating list, mid-operation in fact, I was injecting the intraocular lens into the bag and my patient drifted out of his sedation and asked, "Is it a woman doing my surgery?" Now, arguably, this is not the best time to be checking your surgeon's credentials. And although I was deeply touched at the kindness and thoughtfulness and individuality of this gift, I found within myself a somewhat uneasy tension, debating whether to wear this scrub cap or not. Because to me, it symbolized a crutch that someone thought I needed this to be recognized as an eye surgeon. And it meant being honest about the lenses by which people see me, by which society sees women, even if that patient is educated, even if that person is a female, and especially so when that person is your patient. We use lenses all the time in ophthalmology and in life. They are filters by which we see the world, and they heavily influence our responses to external stimuli. In a purely biological fashion, the lenses we use allow us to become more efficient in our day-to-day lives. These patterns of instant recognition are learned from childhood, honed over a lifetime, and from an evolutionary perspective, allow us to sort good from bad, like with like, and same from different. These lenses encompass ethnicity, religion, sexuality, and of course, gender. However efficient these lenses are in allowing us to make rapid decisions on a day-to-day basis, we should be examining how these very lenses that allow for peak efficiency often blind us to the very prejudices that we claim to abhor. Why? Because the lens through which we see ourselves does not always consciously allow us to consciously and critically evaluate the lenses that we use on others. No one wants to believe that they are inherently racist or sexist or discriminatory towards a certain religion. None of those individuals in those encounters, that retired male radiologist, the female scrub nurse, or my patient on the table, would consider themselves a sexist, and nor did they deliberately mean to be. These small encounters, however, these microaggressions, were not conscious attempts to minimize my value. This cumulative exposure over time, however, This lack of awareness over the gendered tint of our lenses is what I want to talk to you about today. The reality of our male and female vulnerability to unconscious gender bias in medicine and ophthalmology, its contribution to imposter syndrome in women, and how we inadvertently and innocently contribute to the problem. It poses significant disadvantages to our profession and to healthcare as a whole. But by increasing our awareness, challenging ourselves, and channeling this into action, we have the power to turn this around and ensure that we develop and nurture the incredible contributions and talents that women have to offer the world. So, what is gender bias really? Well, the World Health Organization states that gender bias or gender stereotypes are a generalized preconception about the attributes or roles possessed by or performed by women and men. These stereotypes are harmful when it limits men and women's capacities to develop their personal abilities, pursue professional careers, or make choices about their lives. Furthermore, compounded gender stereotypes, this is talking about the intersection of stereotypes, have a disproportionately negative impact on certain groups of women, such as migrant, Indigenous, minority women, women with disabilities, women from lower caste groups, or with lower socioeconomic status. And we commonly think of these transgressions as being overtly hostile, such as women are irrational or women are emotional. But there can also be seemingly benign observations. Women are naturally nurturing. But these are equally harmful stereotypes that perpetuate inequalities. For example, the traditional view of women as caregivers can quickly result in that the majority of childcare responsibilities often fall exclusively on women. The latter, these insidious forms of gender bias, is especially harmful because it silently erodes away at opportunities for women. Oh, I'd love to ask Rosie, but she's probably going to be too busy with the kids. It silently erodes at the confidence of that woman. They never asked me to participate, so I mustn't be good enough. And our confidence in women as a whole. Why are there no female speakers on this panel? Must be because there just weren't any that were good enough. And it is so much more difficult to call this out, especially when we have limited awareness of its existence, because it's that subtle. These insidious forms of gender bias paves the way to a disproportionate amount of women experiencing imposter phenomenon. Imposter phenomenon is a lens that we use on ourselves and can be defined as a psychological lens that causes one to doubt one's ability, talents, accomplishments, and causes us to harbor an internalized and persistent feeling of being a fraud, even in the face of objective evidence that would tell you otherwise. Now, originally coined as imposter syndrome in 1978 by two psychology professors, Plants and Imes, they theorized that women were uniquely predisposed to imposter phenomenon because success for women was contraindicated by societal expectations and their own internalized self-valuations. And that last phrase is key. The inherent problem, however, with this sort of terminology is that it places the onus of responsibility to fix the problem squarely on the individual, in this case, on women. And it is imperative that we recognize that these self-limiting beliefs are fostered by and are the end product of systemic conditioning and implicit bias over a lifetime. Now, imposter syndrome is pervasive, affecting about 70% of all individuals, but there is significant literature to suggest that women are impacted at a greater proportion and greater severity than men. And for men and women, it starts young. It's pervasive. We grow up in a complex ecosystem of gestures and words, actions, and symbolism that reinforce these attitudes. So what are the risk factors for imposter phenomenon, and how does that relate to our field of medicine? Well, amusingly, it is kind of like a checklist of what it took to get into medical school and then into ophthalmology. So we have our family expectations with helicopter parents. We have graduate course level work surrounded by high achievers. If you happen to be in the medical profession or science, technology, and engineering fields, or if you're the first or last in your family, generation, or ethnicity to achieve a certain achievement. Or if you define success in one of 5 ways. The perfectionist, where 99 out of 100 is still a failure. The expert, where I need to get that degree and then that master's and then that PhD before I legitimately feel that I have a place here. The naturally talented, if I have to put work into this, if I have to put any sort of effort towards this, then probably that means I don't have any talent to start with. The soloist, I need to be able to do this completely independently, and that is the only way that I can judge that I'm competent. Or the superhuman complex, commonly affecting mothers, where they're constantly feeling like they're having to juggle so many balls and keep them up in the air all at the same time to feel like they're genuinely on top of anything. And this environment evokes a constant sense of shame, of falling short not only of your own expectations, but that of others. And this shame environment contributes heavily to the way that men and women define success and failure within themselves. Confidence studies have repeatedly demonstrated that women tend to underestimate and men tend to overestimate their aptitudes in circumstances where there really are no measurable or objective differences between genders. Research shows that males are also more likely to attribute their success to their innate ability, whereas females ascribe it to the work that they did to get there. They'll explain their successes away by subscribing it to luck and hard work rather than their innate ability. And when they fail, males tend to attribute that to a lack of interest or a lack of effort, but females are more likely to blame themselves and their total lack of ability. So why should we care? It's because this leads to increased stress, anxiety, burnout, depression, and makes it impossible to derive true joy in your work. And the reason why IBM and Apple and Boeing and the science and marketing companies are all looking so closely into imposter phenomenon is not because it's a sexy and a woke thing to do. It's because they realize that there is a great cost to the individual. They may procrastinate, the fear of not being able to complete it to the necessarily high standards that they set. They may over-prepare, where they spend inordinate amounts of time disproportionate to what was necessary for a successful outcome. Or they may not even volunteer their ideas or volunteer themselves forward for a position. And it is this cost multiplied several-fold over that translates into a huge cost to the organization. Ultimately, it stops women from contributing, and that is a crying shame. Because if we're aiming for equality, then that is 50% of your workforce that remains untapped. Now, I made mention that we, men and women, inadvertently and innocently contribute to this ecosystem. It is not a conscious bias that we exercise on a day-to-day basis. If anything, we in medicine in particular like to think of ourselves as pretty well-versed in gender issues and being pretty sophisticated advocates for gender or equal opportunity. So let's take a look at some examples that sit right on our doorstep of medicine and ophthalmology. Letters of reference. The University of Arizona Medical School evaluated all letters of reference for male and female faculty positions over a 3-year period back in 2009. And letters written for female applicants were found to differ systematically to those that were written for men. On average, letters for men were 16% longer than letters for women, 2.5 times more likely to make a ringing endorsement. He is the best for the job. 4 times more likely to mention his publications, his research, his skills, his career. And conversely, letters for women were 7 times more likely to include personal life, which was completely irrelevant to the application. 50% more likely to include grindstone adjectives describing the woman's effort rather than her ability. Grindstone adjectives like hardworking. and twice as likely to include negative commentary, such as she has a challenging personality. Now, it is vitally important to recognize that the male and female supervisors writing these letters never set out purposely writing in a different way and never used different criteria between their male and female mentees. It is so important to remember that unconscious gender bias is not just a male problem. Women are just as susceptible as men. And this is a really powerful example of inherent systemic bias. So fast forward to 2019, another paper looked at over 1,300 letters of recommendation for male and female applicants applying to UCLA in 2018. No significant differences were found for USMLE scores, GPA, number of academic and service activities listed, and there were equal numbers of men and women writing these letters, and still a gender bias in language occurring today. So why is this relevant? It's because the broader context is that despite women's greater access to educational opportunities, they have been getting a medical degree and law degrees and business degrees since at least the 1970s. It has not resulted in a commensurate movement of women into positions of power in these organizations. And it's not uncommon to hear the rebuttal to this argument. Well, more than half of medical students these days are females, so as if this was somehow a surrogate measure for equality. In 1966, about 7% of US medical graduates were women. But now, even despite women making up more than half of medical school graduates in the Western world, there is still a stark gender difference in the proportion of women in leadership positions and surgical specialties. In 2016, the UK College of Ophthalmologists reported that 3/4 of their consultant population were male. The proportion of US female ophthalmologists over the last 50 years only rose from less than 5% to 1/3, and that's been over the last half a century. This is a far cry from equality. Another eye-opening example is the ophthalmologist's top 100 most influential ophthalmologists in the world. This is 2016, 2018, 2020. We see this pattern again and again and again. These arguments do not acknowledge that there are gatekeeping practices, educational requirements notwithstanding. It is the job interviews, the letters of recommendation, the personal endorsements that control access to these particular positions. And it's important that we recognize that it is these gatekeeping practices through which similar people are selected year in and year out. Selection bias is real, no matter how gender blind we think we are. If I was to run a simple exercise right here in this room right now of the top 10 names of the people you trust the most who are not in your family, chances are they will largely be of the same gender, same race, same nationality, reinforced selection of certain demographics similar to your own. Division of surgical cases. There are many studies to suggest and demonstrate that the female ophthalmology training experience and the female ophthalmology experience as a whole differs to that of their male colleagues. They are more likely to experience increased bullying and harassment, suffer discrepancies in pay, and have less opportunities to pursue research or be involved in leadership. And it starts early in their ophthalmic careers. This is a study from my own backyard of Australia and New Zealand, published this year in 2021. Gill and Danish Meyer looked at gender differences in the division of surgical cases in ophthalmology training over the past decade. They surveyed and looked over the surgical logbooks of some 240 trainees, nearly 200,000 cataract operations. 40% of these were female. Alarmingly, total surgical volume was over 20% lower for females at the end of training. Completed cataract cases were over 20% lower in the first 18 months, and this widened to 40%, over 40% at 4 years. And when they evaluated the impact of whether or not they took parental leave or the duration of parental leave, this was not identified as a significant predictor for the number of completed cataracts. And similar reports have been resulting from the US and UK. And alarmingly, these are all first world environments. It's not difficult to extrapolate what could be happening in other areas of the world. So implicit gender bias is thought to play a pivotal role in the differential treatment of male versus female trainees, but gender normative expectations also play an influential piece in the dynamics of the operating theatre. Studies have shown that women in surgery are held to different standards than men in the operating room. For example, there's less tolerance when women make surgical mistakes, and they are statistically more likely to have complaints filed against them for the exact same behaviors displayed by men in the operating room. Judging CVs. This paper was published in Nature in 1997 by two Swedish ophthalmologists, Swenares and Wald, who looked into why women were getting more PhDs in the sciences but were less than half as successful as their male counterparts in attaining a postdoctoral fellowship. So they decided to go to the Swedish Medical Research Council to evaluate the peer review process and check and see if men and women were being evaluated equally. It took 2 years and a court order because the Medical Research Council was convinced that it was a meritocracy and that their systemic processes were gender blind. And what they found shocked the overwhelmingly male scientific committee. Women did not have to be twice as good. They had to be 2.5 times more productive just to achieve the same score as men. And if I translate that into the amount of work, that means approximately 3 extra papers in Nature or Science with impact factors of 41, 42, or 20 extra papers in factor 3 journals. Now, on average, we are talking about a decade's worth of more work for women just to be considered as equal with men. This is an eye-opening example of unconscious gender bias. This and several other studies strongly suggest that peer reviewers have enormous difficulties judging scientific merit independent of gender. Male achievements can be overestimated and female performances are often diminished. And it is these external perceptions that women absorb and the environment in which we live in, and it becomes very easy to internalize. Now, these are 3 huge examples of the way we have built in unconscious bias and the fragility of systems that were supposedly designed to eliminate this. But it also happens in a subtle yet insidious way. So let's take a look at how we are introduced at conferences and the use of professional titles. In 2019, the Journal of Clinical Oncology found that female speakers were less likely to receive a professional address and were more likely to be introduced by their first name only. In 2017, another study looked at the introduction of speakers at internal medicine grand rounds and found that when the introducer was female and the speaker was male, formal titles were used 95% of the time. And whereas when male introducers introduced female speakers, formal titles were used less than half the time. Now again, the people performing these introductions are not consciously thinking, that's a female, I'll use their first name. That's a male, I'm going to use their title. But again, these are exercises in unconscious bias that we exercise every single day, and these are the intrinsic messages that women internalize. Combating unconscious gender bias requires a systematic deconstruction of the destructive behaviors, gestures, words, and actions used in our ecosystem to reverse the toxic environment in which women are somehow expected to flourish. Let me state unequivocally that unconscious or implicit gender bias and imposter syndrome is not just a women's problem and is not just for women to solve. It actually makes 0 sense to place the burden on women solely to solve the problem. For one, if 3/4 of all ophthalmologists still happen to be male in the US, then the majority of people in those senior roles are inevitably going to be male. And the majority of gatekeeper roles will also be male. So developing a greater awareness and insight into implicit gender bias is an imperative male and female responsibility. So firstly, we need to acknowledge that implicit bias exists and evaluate its impacts. This is a genuine lived reality of a significant proportion of the population. You might choose to sit down and ask your female trainees and fellows, I recently saw a talk on unconscious gender bias and imposter phenomenon, and I'm wondering if it's an issue for you because I'm open to talking about it. Invite them to share and invite their audience to listen without judgment. And then back it up. Objectively evaluate your practice of role hiring, division of surgical cases. Ensure that you de-identify names and remove gender altogether off of the CVs that you're evaluating to make sure that you're truly screening gender blind. Consider the representation of your conference speaker panels and think about instigating the use of quotas, which are helpful as a stepping stone to normalize diversity of choice. Change the way we speak about women. It's about thinking about the way that we write that reference letter compared to if we were writing it for a male applicant, making sure that we are using the proper honorifics for female clinicians consistently, not just on the podium, but in the consult room or even in the tea room. Describe women based on their achievements and professional attributes rather than their personal characteristics and physical attributes. Now, females are often thought of as catalysts for organizational culture change. Increasing female representation in leadership is important because the evidence clearly shows that effective management of diverse and inclusive departments demands diversity amongst your leaders. Institutions that meet gender equity targets are also more likely to outperform those that are not gender diverse. Across the board, however, in medicine, academic medicine, and particularly so in surgical specialties, women remain underrepresented in leadership positions. In one study of the 20 highest ranked ophthalmic journals, only one is a female editor-in-chief. In 2019, females only comprised less than 20% of departmental chairs at US academic centers. So a common retort is women just don't get involved with research or publish as much, so why should they? When you do look at the evidence, however, Dander et al. Found that although men serving as editorial board members had a higher H index than females, once you accounted for the typically shorter length of the female academic career, there was still an overrepresentation of male editor-in-chief and presidential positions, which could not be explained by fundamental differences in the quality of their academic output. In addition, the lack of women leaders as role models reduces the likelihood of junior women in early career positions aspiring to these leadership roles. In other words, if we don't encourage women to take up these leadership positions, junior women in future generations are not going to see that they can fill these roles and nominate themselves. So role modeling is essential. Encourage women to own their accomplishments and not to minimize them. On a public level, nominate them for that position or that award. And on a day-to-day basis, be deliberately specific with your encouragement. You know what? You nailed that clinical case today. You performed excellently in that surgery. I'm really proud of you for publishing that research paper. And if you catch them, whiling away their success to other factors such as luck or hard work or help from others, stop them and remind them to own their own success. Mentor someone and do it actively, taking an active, actual interest in your mentee. Because often by that power differential, they will probably be too shy or too insecure to tell you about an achievement and much less look for support about a failure. And check your unowned unconscious gender bias. Consider actively nominating deserving women or minorities of merit for leadership positions and opportunities, but be aware that nominating a female just because they are a female is demeaning, devaluing, and does nothing to improve the ecosystem. Using gender as a sole criteria for nomination can lead to women being subjected to more criticism. When an opportunity arises, the process should be is that we consider all qualified individuals. So the usual suspects will come to mind first, but an active, intentional step should be taken to include women and other minorities of merit who are equally deserving of that position. And only then does one choose from that extended pool of candidates. And this approach ensures that every nominee is a person of merit, and it expands the opportunities for you to achieve true diversity in your organization. The final step is to be an ally. A good friend once told me allyship is a person who is not a member of an underrepresented or marginalized group, but who chooses to express and give support to that group regardless. So when I think of being an ally, I think about champions of change. When I released the first public iteration of my thoughts in this area, I threw it up online before I went to bed, in the middle of a pandemic, to the ophthalmic community in Toronto, thinking that not much more than our small local community would take notice. When I awoke the next day, it had been shared over 2,000 times, and to date, the video has been viewed over 10,000 times across various social media platforms. I was incredibly touched by the support and generosity of other women who chose to share it on their platforms, in their areas around the world, in their communities. But I was especially taken back by the male champions of change who wrote and asked if they could share it with their residents, who DM'd and tweeted and Insta-storied, who started email threads within various organizations to stimulate discussion and create a safe environment for women to come forward and share their experiences in a way that they could be heard, understood, and an impetus for change created. These were key opinion leaders, residency program directors, fellowship supervisors, industry leaders, and more. And importantly, they were males in senior gatekeeping roles. And I began to see them through a new lens, not as bystanders, but as allies. It normalized men taking implicit gender bias on board, and it normalized the openness of respectful and productive conversations around this topic. And I strongly believe demonstrated a genuine earnestness to help change the system. As ophthalmologists, we have the power to take a poorly filtering, outdated lens and replace them with permanent lenses of clarity. And in much the same way, we have immense opportunity and responsibility to heal the engendered lenses to which we've grown accustomed. So my scrub cap is one such tool. I now see this as a tool helping my patients and colleagues change their lens, their view of my identity, and my role in taking care and the lead to provide the best care that I can for their health, and hopefully not one that I will always need. So one must recognize that we as leaders, doctors, and scientists are not immune to other human beings in terms of prejudice. The awareness of our language, our actions, and unconscious gender bias, and the production of inbuilt systems that are robust to the weaknesses of human nature is therefore of high priority to change that ecosystem. If this is not done, we lose an enormous opportunity for us to work together for the betterment of humankind. Thank you very much.